So I've put up here a few examples of data that could be used from either insurance claims or from routine care records, just to give you a flavour of the different kinds of records that can be used. So I've got some here in the UK. You've got the Clinical Practice Research Data Link. This is the database where I do most of my research, and we will talk a little bit more about that. The Health Improvement Network is another primary care data source, and Q Research. All of these are based on primary care in the UK. Denmark is an unusual case where the entire country is part of a linked record. Everybody in Denmark when they're born is given a number, an identification number, which then follows them throughout life. So their medical treatment will all go under that number. Their education goes under the number. Everything to do with their employment, their tax, everything is linked to that number. And in theory, researchers in Denmark only can access that data to do country level studies where literally everybody in the country could be included. So it's a very unusual situation. Weirdly, the only records that you can't have to do this research on are primary care. So everything else, all their hospital records, all their prescribing, that's all available, just not the primary care data. But anyway, slightly weird situation. In the US, they rely very heavily on insurance claims data. So for example, Kaiser Permanente is an insurance database. And then here in Japan, you have a whole range of data sources which, who is using these data sources here in the room? Who's using any of these? Okay, a few of you are using these data sources. So if others that are not but want to know more about these data sources, you now know who to ask about them. I've never used them, but I think Masao may be able to tell you more as well. Okay. So we know, I showed you this in the last talk, that there's an explosion in the use of these kinds of data to do research. And again, this is the number of primary care publications using the CPRD in the UK. Now, a lot more of these kinds of studies will be done. And as I say, we need to be careful, but in lots of ways it's a good thing because it means that we can investigate these kinds of situations. And I've put these in, I've got bullet points, but basically the sorts of things we can investigate using electronic health records are drug utilisation. That's quite easy, and I'll show you an example in a minute. We can investigate safety signals, or we can investigate known adverse drug reactions. These three we've been doing for many years using electronic health records, and I would say that we've got very well established methodologies for doing it. We understand the limitations, we understand how best to understand the evidence and how to explain it to people. Where we are finding out how to do it is these four, the four at the bottom here. And I will mention these during the talk. So we've got signal detection, measuring drug effectiveness, randomized trials, and historic controls. And these are all growth areas in pharmacoepidemiology where the methods are not so well established, but where there is the potential for growth. Okay. So first of all, drug utilization studies. Now I've got an example here of an assessment report published by the European Medicines Agency. So the agency will assess safety issues in great detail, and they will publish a document that describes all of the evidence that they looked at for this safety assessment. And they're all publicly available. It's a very interesting resource to have a look through. And I've given you one example here, which relates back to the question of sodium valproate and the problem with birth defects. So this is an issue that had been ongoing for several years, and there had been an agreement that what needed to happen was a pregnancy prevention program. Now, the drug is used in epilepsy, bipolar disorder and migraine. And back in 2014, there was some action taken to try to restrict the use in women of childbearing potential and to prevent future pregnancy. So that's the risk minimisation. But the question is, how do we can have this program, but how do we know whether it worked or not? Because what really matters is that women did not become pregnant while taking sodium valproate. That's what matters, not that we had a plan in place. You see the difference? We could only investigate this using routine care data. So there's no point doing a randomised trial, because what we really want to know is, out there in the world, were women receiving valproate and becoming pregnant? That's the only thing that matters. So in order to do this, we need to have access to population level data that's suitable for doing this kind of research. And broadly speaking, for this question, we could split this up into 3 kinds of research. So 3 kinds of data. So first of all, we've got patient level data. We'd want to know the age and the sex of patients amongst our data, because we want to know about women of childbearing potential. So we're not interested in 4-year-old boys or 92-year-old women. We want to know about women of childbearing potential, so we need these demographic bits of information. We also need to know within our data, when did people enter the database and when do they leave the database? So in other words, a defined observation period over which we can find out what happened to these patients. Yeah. So that's your patient data. We also need to have clinical data recorded for them. So we would have diagnoses. I want to know, does this woman have bipolar? Does she have epilepsy? Why might she be taking treatments? So that's the kind of information I'm going to need. We also have signs and symptoms. Might be useful for us to know other things that are happening. And then really importantly, pregnancy. I want to know if a woman who was exposed to certain treatments has become pregnant. Okay. And then finally, I'm going to need to know what treatments people are prescribed. So I want to know the name of the drug, the dates that they were prescribed it, and potentially the dose that they were given. So if I've got within a data source all of these pieces of information well recorded, then potentially I can then use those data to do research to investigate whether or not this problem with valproate was being addressed properly. Yeah? So what happened was, in the European Union, after they made these changes and these risk minimisation suggestions, they commissioned a series of drug utilisation studies in a range of different countries. So in France, they used a large national administrative database, and they were the leaders for this particular process. But they also involved other countries, including the UK, Sweden, Germany, and Spain. Now, there are 28 countries in the European Union, and this isn't all of them. And this is an interesting thing that happens in the EU, is that they won't do a study just in one country, but they will very rarely, if ever, do a study in 28 countries. So they will get an idea of what's happening in a range, but it won't be all of them. They largely used electronic health data in each of these countries to do this research. And what it confirmed was that after 2014, when these risk minimisation processes were introduced, the use of valproate fell amongst the relevant women, but the regulators didn't think it had fallen enough. They thought there was still more usage in women of childbearing potential than there should have been. And because of this, they then made further proposals for how to minimise the risk. So it's really important that they thought they'd made a good plan initially to reduce usage, but it turned out it wasn't the case. And only through doing drug utilisation studies could they then go on to suggest further improvements to those minimisation procedures. Okay? So that's one example of drug utilisation and why it's important. But there are lots of other reasons why you would do this kind of research. So why does it matter who uses the drug? Well, if you link it back to what we know in the risk management plan, we know about the identified risks, we know about potential risks, but there's lots of missing information. And this often relates to not knowing how the treatment will work in subpopulations. And we will only know if this is relevant once we get access to data telling us who is using the drug. So if it turns out lots of people with renal failure are taking the treatment, but they were never studied in the trials, then this is important information that's going to help us to decide what we might need to do next. It can help us to identify off-label use. So we know what indication we give the drug for, but is it what it's being used for? Are people giving it for other reasons? It can help us to identify drug interactions, so we can quickly see what treatments are people taking our drug in combination with, and might this be a problem? We can compare how similar or different the real-world population is compared with the randomised trial population. And we can then start to decide whether the risks and benefits might differ based on these characteristics. So again, similar to the example with the COX-2 inhibitors, where it turned out that in the real world, patients were much healthier than they were in the randomised trial. And then finally, as I've just shown you, you can also use these kinds of studies to see whether or not efforts to minimise risks have been successful.